Thank you very much. First, I'd like to start with echoing what the previous speakers have said, that this session is really important and a step forward. And I'm really proud to take part in this. I'm a pediatric neurologist, and you chose a really difficult topic for this session, targeted treatments, because I myself have all these different patients with rare and complex epilepsy, and for me it's difficult to find out what treatment works best for them. But I'll try to explain a little bit to you what's available now of the targeted treatments. These are my disclosures. So, years ago we started off with an average patient with epilepsy, and we had anesthesia medication, a whole lot of them, and the number of medication available still increases every year. And we based our treatment choices on the efficacy of those treatments, on the adverse effect profile, on the interaction with other drugs, on teratogenicity in pregnant women, for example, and also on the electroclinical syndrome. But we never, in the beginning, and now more and more, take into account the etiology of the patients. And we use these treatments in more or less a trial and error approach. We start with one treatment, it doesn't work, we go to the next treatment, and it doesn't work, we go to the third treatment in this average patient. And then we see, is this patient seizure-free? And we predict the efficacy of the drugs on patient populations, on means of patients. But this is not precision medicine, and this is not how we treat patients now. So I'd like to start with the definition given by the regulators about precision medicine. It's an innovative approach to tailor disease prevention and treatment that takes into account differences in people's genes, their environments, and their lifestyles. And the goal of this precision medicine is to target the right treatment to the right patient at the right time. So we have these individual patients. Patients all differ from other patients. They have their own genetics, they have their own environment, their own lifestyles, socials, and comorbidities. And to consider precision treatment, that requires and includes to have an early and specific etiological diagnosis. So what is the cause of the epilepsy for this individual patient? We want to predict how the course of the epilepsy will move on. We want to personalize and target treatments. We want to modify the disease course in this individual patient. We look therefore at individual outcomes. What is important of the treatment in this patient? And then we make a decision together. What is the choice of the treatment? So, coming to the early and specific etiological diagnosis, this scheme may be familiar with some of you. This is the classification scheme of the International League Against Epilepsy that was published in 2000, for the first time in 2010, and then in 2017 again. And here you see that where we first said, well, there is no cause identified, or there is a cause identified, we now group them into 6 different categories, namely the structural, the genetic, the infectious, metabolic, autoimmune diseases, and we end up with the group that we cannot find the cause. And this is important to know what treatment to give. Because for the structural ones, for example, if we have a focal structural epilepsy, so we have a lesion on the MRI side, and we find that the seizures are well compatible with this lesion, then the targeted treatment is epilepsy surgery. We may also have a genetic cause, and I will talk more about the targeted treatments that we now find in genetic epilepsies, or with metabolic disorders, and substitution and suppletion is also something that I will mention, because in metabolic disorders there can be a deficiency of some protein, enzyme, receptor, or there can be a dysfunction. Inflammatory, we have autoimmune modulating treatments, for example, corticosteroids or immunoglobulins. Infectious can have antimicrobiotics, so we really need to identify the etiology first. If we look at all patients with epilepsy, and I think Professor Berkowitz will tell more about it, but on average about 25% nowadays is identified with the monogenic epilepsy, and especially in the young children. I'm a pediatric neurologist. We find that even when they start really early, a high number of monogenic epilepsies are now identified. But on an individual level, these are all very rare and complex epilepsies, and there's a huge variability between patients. Every patient has his own characteristics. So it's a very heterogeneous group. And what we find is that a lot of these patients are resistant to the anti-seizure medication that we have nowadays. So then we come to the targeted treatments. And for the purpose of this, there are many different pathways in our body. We have the channelopathies, we have the metabolic pathways, we have the mTOR pathways that lead to overgrowth syndromes, but altogether what is the problem in epilepsy, and they all play a role there, is that there is a disbalance between excitation and inhibition. And on its own, every gene that is related to epilepsy, when there's a mutation, it can cause this disinhibition. So for some specific genetic conditions, a certain given treatment is more likely to be beneficial for that treatment. So we can have treatments that are determine the channel dysfunction and target this channel dysfunction, or they correct the metabolic or biochemical consequences of certain genetic disorders. And for the purpose of this talk, I grouped them into 6 different groups. Some syndrome-specific, registered anti-seizure medication that are more likely to be effective in certain conditions, suppletion and substitution, so when there's a deficiency, or and the repurposed drugs that are known to be effective in conditions other than epilepsy, but they may also be effective in epilepsy. Then I will briefly mention gene therapy because it's still in its first steps, and pharmacogenetics. So one may think, well, is a syndrome specific or a seizure specific, is it still targeting? Well, in some cases it is. For example, in infantile spasm syndrome, previously known as West syndrome, we know that hormonal therapy may be very effective. In Lennox-Gastaut syndrome, we know that certain treatments are more effective than other treatments, as well as in Dravet syndrome. And even certain treatments are more effective in certain seizure types. For example, ethosuximide is very effective in absence seizures, especially in relation to childhood absence epilepsy. And these are the knowledge that hormonal treatment, corticosteroids, was effective for infantile spasms is already reported, decades ago in the early 1950s. And it has been confirmed years and years later, again and again, in high-level randomized controlled trials, that prednisolone is very effective in patients with West syndrome. More recently, it came to interest that fenfluramine, a newer drug, can be effective in patients with Lennox-Gastaut syndrome and patients with Dravet syndrome. And this slide shows you that when you compare it to placebo, patients with a lower dosage have 30% more seizure reduction, and patients with higher doses can have up to 60% more seizure reduction in patients with Dravet syndrome. And in Lennox-Gastaut syndrome, it's a little bit less effective, but still more effective, significantly more effective than placebos. So this is more related to the syndrome. Then I would like to move to the next group, which is the registered anti-seizure medication. And this, there you find all these codes that code for genes. Somebody yesterday said it's more like a flight number, but it's coding for genes as well. And you have to first understand that there are certain genes that result in a loss of function, where variants result in a loss of function when there's no functional protein. And proteins are important for many working mechanisms in our brain. But there are also genes that can lead to a gain of function, where there is an altered protein, often in a toxic manner. So when there is a loss of function in the sodium channel gene SCN1A, then it's better to avoid sodium channel blockers because there's already not enough protein. And when you block the channel, it may result in an aggravation of the syndrome. And it's the opposite. In gain-of-function mutation, you need sodium channel blockers if the sodium channel is involved. So I would like to illustrate this by a publication of 2018 where 164 patients with SCN1A epilepsy, Dravet syndrome, were studied. And what they found, they looked at cognition over the course of the disease. And they looked at patients who were identified later to have Dravet syndrome, who first were treated with these sodium channel blockers. So it's actually contraindicated medication. And when they were compared to patients who were only treated for a short time with the sodium channel blockers, there was a difference in cognitive outcome. So patients who were treated for a shorter period did better than patients who were treated for a longer period with mutations, with the treatments that should be avoided. On the opposite, patients with the so-called SCN8A epilepsy may benefit from sodium channel blockers. This is a busy graph, but actually what it tells you is that sodium channel blockers are more effective than other type of treatments. But we face here severe epilepsies. And often, although they may be more effective, patients very rarely become seizure-free. But they may be more effective. So also, seizure reduction is an important goal. This is a very busy slide listing all types of different metabolic disorders, and you don't want to remember this, but I want to highlight two of them. And one was already mentioned, it's the glucose transporter deficiency syndrome. So the colleague who spoke on the ketogenic diet explained that our brain needs glucose as fuel. To have energy. And when the transporter to transport the glucose from the blood to the brain is deficient, our brain doesn't have enough fuel. So we need to give a treatment that compensates for that. And that is the so-called ketogenic diet. And interestingly, the ketogenic diet may be more effective for a certain symptom of a certain condition than for another symptom. So this study of 270 patients showed that it was very effective for epilepsy and movement disorder, another manifestation of this disease, than it was for cognition. Still effective, but much lower effectiveness was seen. And also the duration, how long does it take to see improvement, differed from the manifestation. For epilepsy, it was noticed already in weeks. But for movement disorders and for cognition, it was noticed only in months. So this is that the treatment can be effective, but for some symptom more than for other symptoms. And the duration differs. This is a condition that is called pyridoxine-dependent epilepsy. Some of you may have heard of it. Its pyridoxine is also vitamin B6. And when there's a deficiency or lack of vitamin B6, the vitamin B6 is also an important co-transporter in the brain, and that may again give this disbalance between excitation and inhibition. And with this study, I want to highlight that it's important to treat early. There were 18 families, and in these 18 families, there were 37 patients. So there were many patients related, and within the families, people were treated early, and they compared those versus people who were treated late with the pyridoxine, so the vitamin B6, also in conjunction with lysine reduction therapy. This is also can be important in these patients. And they noticed the family members who were treated early improved more when you looked at overall development, cognition, behavior, and psychiatric manifestation than the family members who were treated at a later age. So it is important with these targeted treatments to treat as early as possible. But of course, we come back here to the specific etiological diagnosis. We have to try to make those diagnoses really early in the course of the disease. So another group I mentioned, again, all these numbers, all these genes, they all code for genes. There are many epilepsy genes, as Professor Berkowitz will tell you. But the repurposed drugs are drugs that, for example, are registered for a certain condition. So when we look at the first one, quinidine is registered for arrhythmia, cardiac arrhythmia. But it is found out that it can bring the problem with when there's a variant in this gene, the KCNT1 gene, it can bring the balance back between excitation and inhibition. And it also is the truth for the other treatments for this specific genetic epilepsy. And I would like to give you some example on their efficacy, because it has been reported for small series of patients, are these repurposed drugs really effective? Because they sound really, really promising, but they don't work for all the patients, unfortunately. So if we look at this medication for aminopyridine in KCNA2, a specific monogenic epilepsy, they collected 11 patients from the literature. Some of them were treated early, already at 7 months. Others were treated when they were already 38 years of age. 9 of the 11 patients improved. So that sounds fair enough. Some of them were free of seizures. They improved also in gait, alertness, cognition, and speech. But on the other hand, you also have patients who were treated with L-serine for a certain condition which is called GRIN mutation. And there, again, some manifestations improved. Behavior improved a lot in 8 of the 9 patients who were treated with this treatment. But development and seizures, only 4 of the 9 patients improved for seizures and development. So the manifestation, and it doesn't work for all. But on the other hand, the treatment was well tolerated. So it may be worth a try. This is a very recent publication from a group here from Dublin who looked at Gator. This is a very difficult scheme, but this is an mTOR pathway, so it's a very important pathway in our brain that has to do with protein synthesis, with receptors, with proliferation of the brain, very important. And when there is a problem in the 3 genes that you see a circle on, it can lead to overgrowth and also to epilepsy. And when you try to inhibit this overgrowth production with a treatment that is called everolimus, it was seen that 3 of the 5 patients improved, and they improved a lot, 74 to 86% seizure reduction. And 1 patient also improved, but less, 43% seizure reduction, and 1 patient worsened. And now I come back to the quinidine, and here are many different series. They all report between 17 and 43 patients, and here actually the targeted treatment, the repurposed treatment that sounded so promising was much less effective. We see that now seizure reduction, and when you look at the gram, seizure reduction of more than 50% is only found in 25% of the patients. So this is not too well, and actually it was seen that non-targeted treatments, for example the ketogenic diet or CBD or vigabatrin, was more effective than the repurposed drug. And this has been studied already in 2010 when there was a group of patients who may have been, who had monogenic epilepsy, and for 56 of them, there was a targeted treatment available, and it was given in 33 patients. A small number, but I think the efficacy is still the same. So 30% of these patients respond well to those repurposed drugs. And the problem is that, what I already mentioned in the beginning, that the phenotypic heterogeneity is huge. So all these patients are very different from one another. And it's small and retrospective case series. What we need to do is to define first, before we start our treatment with the parents and the patients, what is our goal? What do we aim for with this particular treatment? Is it seizures? It may also be behavior or quality of life or other outcome measures. So when we start a treatment, we want to define what should be the outcome measure. Because the treatments that were given had different outcomes, different treatment regimens, and they were, as I mentioned in the beginning, given in a trial and error approach. Let's try and see how it works. But the small number of patients with a certain genetic mutation hampers large, really high-level evidence, randomized controlled trials. So we need to think a step ahead in other trial designs. And this is the N1 trial, where the single patient is being studied, and we look for the best treatment in this individual patient. And how do we do this? We give this patient, in a multiple crossover trial design, a certain treatment that may be beneficial. So, and we look at efficacy and tolerability. So in one period, the patient gets the treatment. In the other period, he doesn't. And then again, he doesn't, and he gets the treatment. So in multiple blocks, you can find high-level evidence of the efficacy in individual patients. And important is that you predefine with the patient your outcomes. Beforehand, you tell the patient, this is what we aim for. And you have standardized measures of effect. And this prevents unnecessary continuation of ineffective treatment, because if the treatment is ineffective, we don't want to continue for years and years. But we also don't want to stop it if we're not certain that it's not effective. So we prevent too early discontinuation of potentially effective treatments. So I want to briefly mention gene therapy. So there's DNA, there's RNA, and there's protein. And most of the treatments that we were using were targeting the protein. And those have to be given daily. And we talk about gene therapy, we have the first two groups. So we have the DNA and we have the RNA. And actually, the DNA has all our genetic background, but it does not transform directly to the protein. For that, we need the RNA. The RNA takes the genetic code from the DNA and then transforms it to produce the proteins. And so we may want to change the DNA, which is very difficult. There's trials and are now underway, mainly in animals at the moment. So you want to correct the mutation by editing the gene, or by repairing the gene, or by replacing the gene. And that will lead to a one-time all treatment, but we're not there yet because there are many, many difficult challenges. And then there's the RNA therapy. So you can try to change the RNA that also has a function on the protein. But because the RNA, that needs repeated dosages, so you have to do it every month. And maybe if you heard of the spinal muscular atrophy, a certain syndrome, when this treatment is being registered for the first time in neurological diseases. And these are many different conditions where gene replacement or gene substrate reduction therapies are now being studied. And I don't want to go into detail about on these, but I just wanted to give you some examples. So their first steps are taken in this direction. And finally, I want to mention the pharmacogenetics, something that it's not something that we often routinely implement in our clinic, but there are some effector systems when there are polymorphisms or variants that may cause a loss of function. Then enzymes who are important to for your response to certain anti-seizure medication can be result when there are variants to a lower clearance of the drug. And with a lower clearance of the drug, the patient may experience more severe side effects. So it's important to understand why, if there are variants in these enzymes or in certain transporters, that may predict how an individual will respond to a certain drug. And I think it's important to know more about the different types of metabolizers. It will not tell you all the time whether the patient will tolerate the drug well or not, because there's many other things that's going on, but it will help us to understand more about the different metabolics and to be able to say, well, this patient we need to start on a lower dose. Well, on the other patient, we need to start on higher dosages. Also, more targeting our treatments. So to conclude, precision therapies or targeted therapies require an etiological diagnosis. We really have to make an effort to find out what the causes is of the epilepsy for the individual patients. And then the efficacy varies for the different etiologies. And there are many who are still drug resistant, but we may be able to improve the lead to seizure reduction and therewith also improve the quality of life. But the timing of these treatments is very important. We need to start as early as possible. And find the first steps for gene therapy in humans are underway. I'd like to thank you for your attention.
Thanks very much, Dr. Floor Jansen. Just one question for yourself that we have picked, because there's a lot of questions coming in. And what are the treatments you would recommend and find most effective for children with tuberous sclerosis and refractory epilepsy?
Well, the first choice of treatment in tuberous sclerosis is vigabatrin. Well, actually, there's been 2 trials, and the EPISTOP trial, a European trial, looked even at starting vigabatrin before clinical seizures were noticed. And they looked at EEG markers to look when should we start the treatment. And it's actually when there's a high risk of epilepsy. For example, if you have a lot of abnormalities on your MRI, and if you have a TSC2 gene mutation, I think you should start vigabatrin really early. But also, patients with tuberous sclerosis vigabatrin may not be effective, but in many of these patients, we do not consider epilepsy surgery enough. And I want to stress that also those patients should be evaluated for epilepsy surgery.
That's great. And thanks very much, Dr. Floor Jansen. So
Okay.
we will relieve you of your duties tonight. Thanks very much.